This is the second part of the left side obstructive lesions lectures. Subvalvular aortic stenosis may be associated with other congenital heart diseases, including Schonn's complex or after VSD closure. Because when taking the sutures of the VSD patch, the sutures may narrow the subvalvular area or the LVOT, causing a subvalvular aortic stenosis that is iatrogenic. This is the subvalvular aortic stenosis in the form of subaortic membrane. This is the subaortic membrane, a membrane just below the aortic valve. It may be adherent to the cusps, but in this case they are not. But or maybe there is some adherence here. This membrane may be close to the aortic valve or far from it. So when doing the echo, we should report the distance between the subaortic membrane and the aortic valve. It differs in the prognosis because a membrane that is just below the aortic valve or adherent to it may render the surgery more difficult, with a high risk of injury to the cusps, causing aortic regurg. This is also a subaortic membrane. And if you will notice that the gradient starts from below the valve in this area. This is the pisa for the blood flow. This is also a membrane below the aorta, subaortic membrane. Preoperatively, we take history, the age and height and weight, history of low cardiac output, congestive heart failure, failure to thrive, signs of LV ischemia. So this history taking is similar to the aortic stenosis, because the subaortic membrane is usually a static stenosis, not a dynamic stenosis. But a subvalvular aortic stenosis that is dynamic is a HOCM, or HOCM hypertrophic obstructive cardiomyopathy is also an example for subvalvular aortic stenosis. So a long-standing LVH may cause diastolic dysfunction, pulmonary hypertension. Abnormal blood flow across the aortic valve may lead to its thickening, causing valvular aortic stenosis and subsequent aortic regurg. So, if you will notice here that after the narrowing, the blood accelerates, so it passes rapidly across the cusps of the aortic valve. This high velocity of blood may cause the cusps to thicken, and then later a valvular aortic stenosis may develop. So in a long-standing case of subaortic membrane, we may expect that there is a concurrent valvular aortic stenosis. A resection via aortotomy. It's a simple operation unless a complication occurs. High recurrence rate. Part of the SAM may be adherent to one of the AV cusps. A resection may injure the cusp, causing aortic regurg. In the tubular type, sometimes the membrane is not a membrane, but it is a narrow tube, not just a membrane, but the whole LVOT is narrow. This is the tubular type, so a simple resection is not possible, so we may need a cono procedure. We'll explain it later. In aortic regurg, aortic valve replacement or Ross-Cono procedure. Intraoperatively, we keep hemodynamic goals. See, check the gradient, and by DTE we check the gradient as we said before in the previous lecture. The continuous wave Doppler mean gradient accurately predicts the real transvalvular gradient, but overestimates the peak gradient due to the difference between peak-to-peak measurement by the cath lab and instantaneous difference between the left ventricle and the aortic pressure measured by the echo. The membrane may come in the form of a thin, discrete membrane of endocardial or fibrous tissue, as we have seen in the previous echoes. A fibromuscular ridge from the interventricular septum. A circumferential fibromuscular ring from the anterior mitral leaflet. Diffused tunnel-like fibromuscular obstruction, and this is difficult to repair. Anomalous attachment of the mitral valve leaflets or mitral chordae. So we should keep in mind that a repair of a subaortic membrane may change the anatomy of the mitral valve or even injure it, causing a mitral regurg. LV hypertrophy, dilatation, and LV function, and other anomalies. Post-bypass, we check the LVOT gradient. Usually we don't need inotropes unless there is preoperative cardiomyopathy, congestive heart failure, or LV dilatation, or the TE shows segmental motion abnormalities. Good filling to support the hypertrophied LV. Avoid hypertension to avoid bleeding from the aortotomy. Heart block is common because we may take part of the septum with the resection, so we may injure part of the conducting system. TE post, we check the LVOT gradient, presence of aortic regurg, and the LV function. Talking about the supravalvular aortic stenosis. It may be associated with Williams syndrome, which may be associated also with pulmonary stenosis and RVH, right ventricular hypertrophy. It is an elastic tissue defect, so all these arteries may be associated with the syndrome. The aortic valve may be bicuspid. Age and weight, history of low cardiac output, the same. But we may have a coronary narrowing, may be present with Williams syndrome, causing further ischemia. So with Williams syndrome, the ostia of the coronaries may be narrow. Surgical, we increase the diameter of the aortic valve by a patch annuloplasty, Ross or Roscono procedure, patch augmentation of the stenotic coronary or cabbage, and for pulmonary stenosis, balloon pulmonary valvuloplasty or surgical correction. This is a supraortic membrane. We put a patch here, and this is the most common treatment or management for these patients. Williams syndrome may be difficult intubation, the syndrome itself, due to its facies. Abnormal skeletal muscles may need monitoring of neuromuscular blockade. Keep hemodynamic goals, like any case of aortic stenosis. Williams syndrome may have hypertension, renal insufficiency. Coronary stenosis may cause dangerous ischemia during induction. Readily available cardiopulmonary bypass or ECMO is advised, since CPR may be challenging in these patients because of the aortic stenosis. CPR is generally challenging in any aortic stenosis patient because of the fixed cardiac output, so compressions may not provide enough stroke volume. Check the gradient. Continue, as we have said before, usually comes in the form of concentric narrowing of the sinusotubular junction, hourglass appearance, or diffuse narrowing of the ascending aorta, LV hypertrophy and dilatation, and LV function, and other anomalies. Post-bypass, check the LVOT gradient. Usually we don't need inotropes unless there is preaortic cardiomyopathy, as we have said before. Good feeling to support the hypertrophied LV. Avoid hypertension to avoid bleeding from aortotomy. Ischemia may be due to narrow coronary orifices. So these cases are generally managed as an ischemic patient and an aortic stenosis patient. LVOT gradient, LV function. Now, hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is a disease in which the myocardium hypertrophied abnormally. What concerns us is the hypertrophic obstructive cardiomyopathy, that is hypertrophy in the outflow tract, or in the subvalvular area, or in the septum, just below the outlet, causing narrowing and obstruction. Because HOCM, hypertrophic cardiomyopathy can come in many forms, in maybe the whole ventricle, the lateral wall, the right ventricle, but all these are managed medically. But what needs surgery is the hypertrophic obstructive cardiomyopathy that causes obstruction to the outflow tract to the aorta. It's associated with insulin-dependent models, mitochondrial diseases, Pompes disease. It's a glycogen storage disease causing severe hypertrophic cardiomyopathy and death within a year. Noonan syndrome may occur anywhere in the left ventricle myocardium, but if occurs in the anterior interventricular septum, it causes HOCM. Age and weight, history of low cardiac output, angina, exertional dyspnea, syncope, failure to thrive, and sudden cardiac death. In the family history, sudden cardiac death as a family history. Signs of LV ischemia due to LV hypertrophy. There may be subendocardial ischemia, which later develops to fibrosis that cause impaired function. Intramural coronaries may further increase ischemia. And sometimes there is bundle branch block in these patients. History of arrhythmia, family history of sudden death, ECG left axis, LVH, LV strain, cardiomegaly in X-ray. Long-standing LVH may cause diastolic dysfunction and pulmonary hypertension. Systolic anterior motion of anterior mitral leaflet may cause mitral regurg. When there is subvalvular narrowing, the blood accelerates below the anterior mitral leaflet. So this acceleration causes suction or Bernoulli effect, in which when blood accelerates, it creates a negative pressure around, so it pulls the mitral valve and preventing it from closing or from meeting the posterior mitral leaflet, causing a systolic anterior motion of anterior mitral leaflet, causing mitral regurg. And the mitral regurg, the jet is usually posterior directed. This is systolic anterior motion of anterior mitral leaflet. The blood accelerates and pulls the anterior mitral leaflet towards it, further narrowing the LVOT. Surgically, we may need an ICD for recurrent ventricular tachycardia. ICD is a intracardiac defibrillator for recurrent ventricular tachycardia or ventricular fibrillation, because the fibrosis in the myocardium that occurs with the cardiomyopathy may affect the conducting system and cause the circuits of ventricular tachycardia or fibrillation. Surgery is needed if the gradient is more than 60, if the patient is symptomatic, if there is a mitral regurg. The surgery is a septomyectomy via aortotomy, may need the mitral valve repair. Sometimes a coronary, usually the LAD, runs an an intramural course in part of its anatomy. So this intramural part of the coronary may resemble an ischemia, or during during contraction of the ventricle, it narrows the coronary. So if the condition is more than mild, deroofing is needed, or CABG if it is unrepairable. Hemodynamic goals: maintain good preload due to the LV stiffness. If there is congestive heart failure, diuretics are preferred. Maintain low normal rate, avoid tachycardia. Maintain sinus rhythm and aggressive management of tachyarrhythmias. Contractility: avoid increasing contractility. This is a dynamic obstruction, so we avoid increasing contractility. Avoid inotropes or drugs with positive inotropic effect. Avoid sympathetic stimulation. Good analgesia and anesthesia. Avoid hypercapnia, hypothermia, and hypoglycemia that would cause a reflex increase in sympathetic stimulation. Beta blockers may be used. Those patients are usually on beta blockers. Make effort to increase myocardial supply and decrease demand. Avoid tachycardia. Avoid profound bradycardia. Decreasing cardiac output and diastolic pressure that perfuse the coronaries. Avoid anemia. Avoid hypoglycemia and hypoxia. What is also important is to maintain high systemic vascular resistance, to maintain blood pressure in the presence of a fixed cardiac output, and to stent when we increase the afterload. Here, when we increase the afterload here, we stent the LVOT, so forcing the LVOT to remain open. So in a dynamic obstruction, like in the tetralogy of Fallot, we maintain high systemic vascular resistance to keep the stenosis, to keep the stenotic part stented by blood under high pressure. Be very careful with inhalation induction if needed, and better avoid inhalation not to lower systemic vascular resistance. Ketamine is good. Opioid-based induction is preferred. Check the gradient. The wave looks like a dagger. It's dagger shaped due to the dynamic obstruction, as opposed to the when there is a fixed obstruction. The wave is parabolic like this, with the peak in the middle, in the mid systole, during the maximum flow of blood. But in dynamic obstructions, the gradient is late systolic, because during systole the muscle contracts, so the gradient increases until just before the end of the systole, the muscles are at their maximum contractility, causing the maximum gradient. Then the diastole begins, and the muscles relax, and the gradient drops. Systolic anterior motion of anterior mitral leaflet. Check the mitral regurg. Measure septal wall thickness. If it is more than 15 millimeters unexplained, or the septal wall thickness as a ratio with the posterior wall thickness is more than 1.3 and 1.5 in hypertensives, this diagnoses an asymmetrical ventricular hypertrophy. Measure the distance between the aortic annulus and the point of contact of the septum with the anterior mitral leaflet, the site of myectomy. So we measure the distance between the point of contact of the mitral leaflet with the septum, and the distance of this point from the annulus. So if we go back to this patient, we measure this is the distance, this is the point of contact, so we measure this thickness and the distance between this thickness, this point, and the annulus, because the surgeon will come through here, through the aortotomy, will measure this distance, and then he he will do the myectomy. He will take part of the myocardium. So this is a half-blind procedure. He cannot see the whole septum, so he has to know what depth will he cut, not to cause an iatrogenic VSD. LVH and dilatation. LV function, check the mid-cavitary obstruction in both ventricles. Later fibrosis and ischemia may cause left ventricular wall thinning and dilatation. This is a mid-cavitary obstruction because, as we said before, the left ventricle may be hypertrophied in any part of it, or maybe the whole ventricle is hypertrophied. So a mid-cavitary obstruction may be found in these patients. This is a static obstruction. The peak is mid-systole at the maximum flow of blood across it, and this is the dagger-shaped or late systolic peaking of the continuous wave Doppler wave. Seen in dynamic obstructions like HOCM and in tetralogy of Fallot. Check the post-bypass, check the LVOT gradient. Usually we don't need inotropes unless there is a preoperative cardiomyopathy, congestive heart failure, LV dilatation, or motion abnormalities. Good filling to support the hypertrophied left ventricle. Bundle branch block or heart block are expected and may be permanent due to injury of the path of the injury of the conducting system during resection. The bundle of His and the anterior and posterior bundle branches, the left and right bundle branches, and the fasciculi of the anterior and posterior fasciculi of the left bundle branch pass through the septum. So the myectomy may injure one or all of these fibers, causing either a bundle branch block or a complete heart block. If deroofing of an intramural corona is done, bleeding is expected. Much bleeding is expected because we do not use cautery on the myocardium. So we rely on compressions with the gauze. So hemostasis of this, even if it is a small deroofing, but the bleeding is usually much, and we should expect it, and we should prepare adequate blood products. Post-bypass, LVT gradient, presence of aortic regurg, LV function, check for residual subaortic membrane, anterior lateral leaflet, and for mitral regurg, check for iatrogenic VSDs. Okay, we'll talk about the coarctation of the aorta. Usually just distal to the opening of the left subclavian artery. So just at the end of the arch and the beginning of the descending aorta, at the point of insertion of the ductus arteriosus. Usually a short segment, but can be a long segment and can associate with hyperplastic aortic arch. Severe coarctation may cause PDE-dependent descending aorta flow. So the PDE supplies the descending aorta so the lower part of the body is dependent on the PDE. And these patients are usually neonates, and they need intervention, and they need prostatin to keep the PDE open. Prostaglandin E1. Sometimes there are collaterals to supply the lower body. So we may find that the difference between the upper body and the lower body blood pressures are not that great while the coarctation is severe. So the presence of these collaterals may explain why the lower body pressure is high despite a tight coarc. We have said that usually the coarc is at the point of insertion of the ductus arteriosus. It is speculated that the cause of the coarctation may be due to migration of some of the cells in the ductus arteriosus to the arch. So when the ductus arteriosus closes after birth, the coarctation narrows because the same cells are here and here. So those cells, when they find the PO2 of the blood increases after birth, they close spontaneously. So this may be one of the causes of the coarc. Severe coarc in neonates, when ductus arteriosus closes, LV failure, congestive heart failure, pulmonary hypertension, upper body hypertension, very common, coronary artery disease, stroke, heart failure, rupture aortic valve, cerebral aneurysms. So these patients are usually on antihypertensive drugs, a gradient assessment by thoracic echo, anatomy confirmation by the CT. Patient may be on inotropic support and diuretics in severe cases, prostaglandins in PDA-dependent systemic circulation, as we have said before, when the lower body is dependent on the PDA. Surgically, balloon dilatation and stent for older patients. Recurrence is common. Surgical repair for neonates and infants. Coarctation segment resection of bypass. This is the usual operation that is done with a thoracotomy, a lateral thoracotomy. Aortic arch advancement in cases of hypoplastic arch with cardiopulmonary bypass, and also hypothermic circulatory arrest in cases of arch repair. This is a balloon dilatation and stenting. This is the stent. This is the surgical correction. They resect this part and then they suture with direct anastomosis, or by if the arch is small. So this is the arch advancement technique. Position, either sternotomy or left thoracotomy, according to what surgery will be done. Ensure no leak and no endobronchial intubation, especially with thoracotomy. And especially we should make sure that the tube is not in the non-dependent lung, because if the tube is, the endotracheal tube is endobronchial in the non-dependent lung, when they open the thorax, the lung will collapse and no ventilation will occur, and the patient will become hypoxic or may arrest. So we should make sure before, after intubation and after positioning the lateral decubitus position, that the endotracheal tube is in the trachea and that the air entry is bilaterally equal. Arterial line in the right radial and the femoral artery. So we should put the radial artery preductal and away from the duct in the right radial artery, and another one postductal to measure the difference in pressure. Why don't we cannulate the left radial? And the left radial is preductal. So why the right radial and not the left radial? Because during the operation, the clamp may close the left subclavian artery. So the measurement of the left radial artery may stop. During clamping, during clamp time, the clamp may stop the blood flow to the subclavian artery, so the radial artery won't read any measurement during the clamp time. Lung collapse, we open FI2 to 100 or 1, low tidal volume, high respiratory rate, recruit after inflation. Permissive, mild hypercapnia can be tolerated unless there is pre-existing metabolic acidosis from systemic hypoperfusion. In these cases, mild respiratory acidosis is dangerous. So we may tolerate some hypercapnia unless the patient will be harmed greatly. Cerebral oximetry in cases of congestive heart failure, low body hypoperfusion, renal and spinal ischemia. Mild hypothermia is indicated to decrease spinal cord ischemia, so we do not use bear hugger in these patients. Avoid upper body hypertension in troops during cross clamp may be needed in cases of LV impairment, because the clamp may increase the afterload on a failing left ventricle, so we may need an inotrope during clamping. Measure cross clamp time. It should not exceed half an hour. At the declamping, hypotension may occur with distal vasodilatation and metabolites release to the circulation, causing reperfusion injury. So we should correct metabolic acidosis. We should be ready with vasoconstricting agents like phenylephrine and noradrenaline. And we should be ready for a pre-arrest or for an arrest. So all the emergency drugs should be ready with us. And after declamping, we should take an ABG sample and check the presence of metabolic acidosis if it needs correction. Post-operatively, hypertension is expected. We may need GTN or sodium nitroprusside or resmolol. Consider Marcaine local injection thoracotomy to decrease for analgesia, to decrease pain. Thank you.